You know the scene. A character suddenly stops, gasps, grabs the center of their chest, and winces as pain shoots down their left arm. We've seen that sequence so many times, it feels like a universal medical truth. But expecting a heart attack to always look exactly like that is a dangerous oversimplification of how our bodies actually work. Look at how the chest cavity is laid out. The heart, lungs, and esophagus are tightly packed together. Because they share such close quarters and nerve pathways, the body's internal alarm system frequently crosses its signals. When we rely strictly on that dramatic, chest-clutching image, huge portions of the population end up ignoring or misinterpreting their own life-threatening symptoms. To accurately spot a fatal cardiac event, we have to throw out the script. We need to look at what is actually happening inside the chest, across different bodies and conditions. Because of that tight anatomical layout, several non-lethal conditions perfectly imitate cardiac distress. This graph charts the onset of symptoms. A panic attack creates a sudden psychological surge that peaks within 10 minutes and usually resolves without causing radiating physical pain. A heart attack, shown here, is a sustained, escalating progression. Indigestion also mimics these warning signs. When you eat fatty or spicy foods, stomach acid can splash up and burn the esophageal lining, sending a sharp pain right through the center of the chest. The critical way to triage this comes down to the trigger. If that chest discomfort happens after a meal, it's likely acid reflux. But if the pain strikes during physical exertion, the probability of a cardiac issue spikes. Tracing the pain back to its immediate cause, whether you just ate a heavy dinner or just climbed a flight of stairs, is often the fastest way to tell if an anomaly is harmless or potentially fatal. Curious, shifting gears. Beyond these imposters, the biology of a heart attack changes drastically depending on your sex. The medical baseline has long been the male heart. In men, cholesterol plaque typically builds up inside the largest coronary arteries until it blocks blood flow. Women have smaller hearts and narrower blood vessels. Instead of clumping in one large artery, plaque often accumulates in the microvasculature, the vast network of the heart's smallest blood vessels. A blockage spread across these tiny vessels doesn't always cause that crushing center chest pressure. Instead, it triggers systemic alarms: nausea, sudden sweating, vomiting, and sharp aches in the jaw or back. Because standard diagnostic tools, like cardiac catheterizations, are specifically designed to spot blockages in large arteries, they frequently miss this microvascular damage. By calibrating our primary cardiac tests to a strictly male physical baseline, the medical system routinely allows female heart attacks to evade detection until it's too late. The aging process introduces its own set of complications, actively silencing the alarms we rely on. Over decades of use, the cardiovascular system physically degrades. The walls of the left ventricle can thicken by up to 25%, and the heart valves gradually become thicker and stiffer. Look at this data charting symptom frequency by age. Between ages 65 and 75, the majority of patients still experience normal chest pain. But by age 85, that number plummets. Only 40% of patients in that bracket report any squeezing pressure at all. Without the chest pain, elderly patients manifest entirely different signals. A heart attack might present as extreme, unexplained fatigue, a sudden fainting spell, or severe shortness of breath, known clinically as dyspnea. These age-induced anatomical changes completely mask the most recognizable indicator of a heart attack. It allows fatal cardiac events to easily masquerade as nothing more than exhaustion. Cardiac symptoms exist on a broad, unpredictable spectrum, dictated by your age, your sex, and the layout of your chest cavity. So if you or someone nearby experiences any new, severe, or unexplained chest discomfort, the absolute first step is to dial emergency services immediately. Do not wait to see if the symptoms pass, and do not attempt to drive the patient to the hospital yourself. Paramedics can begin life-saving treatment the second they arrive. While you wait for an ambulance, there is an immediate medical intervention you can take. If the patient is alert, instruct them to chew and swallow aspirin. You can use one 325 mg adult tablet or 2 to 4 81 mg low-dose baby aspirins. However, you must withhold this intervention if the patient is unconscious, has a known aspirin allergy, or has been specifically advised by a doctor not to take it. Surviving a heart attack requires us to recognize these atypical patterns as they happen. If we wait around for the Hollywood version to show up, we might run out of time entirely.